Welcome to the deep dive. Today we're plunging into a really significant area of veterinary medicine, canine acute lymphoblastic leukemia. We've got some quite detailed information here, painting a picture of, well, a pretty serious condition in dogs.
That's right. Leukemia, fundamentally, it's about the bone marrow, isn't it? A rapid increase in abnormal cells. And acute lymphoblastic leukemia, ALL specifically, that's this runaway growth of immature white blood cells.
Immature white blood cell, prolymphocytes and lymphoblasts.
Exactly, prolymphocytes and lymphoblasts. And the information notes they're most often B-cell origin in dogs.
Okay, so these abnormal cells are just multiplying like crazy in the bone marrow.
Mhm.
What's the sort of the main problem with that?
Well, the core issue is something called myelophthisis. Basically, think of it like these abnormal cells just crowding out everything else. They suppress the bone marrow's ability to make normal blood cells.
Ah, okay, so you end up with shortages.
Shortages of red blood cells, normal white blood cells, platelets, all the things the body absolutely needs to function properly.
Right. Things for carrying oxygen, fighting off infections, clotting blood, crucial stuff. And these abnormal cells, they don't just stay in the bone marrow, do they?
No, that's a key point. These neoplastic lymphoblasts, these abnormal dividing cells, they usually get into the bloodstream. And what's interesting is how they can then sort of infiltrate other organs,
Right.
like the spleen, the liver, even the lymph nodes. They can spread quite widely.
Okay, so that's the big picture. We're narrowing it down now to L-all, specifically in dogs. The info we have gets quite specific about which dogs tend to get it. Interestingly, no real sex preference mentioned.
Yeah, unlike some other cancers, it seems to affect males and females pretty equally. The mean age reported is about 7.4 years.
Yet there's a big range there.
A really wide range, yeah. From 2 years old up to 12 years, so it's not just an old dog disease.
And it seems size matters.
Yeah.
Large and giant breeds are mentioned as having a higher occurrence. Does our info say why?
It doesn't specify a reason, no. Could be genetic links or just something we observe statistically right now. It does contrast this with cats, though.
Right, rarer in cats, affects younger ones, and often linked to FeLV, the feline leukemia virus. That's a big difference.
Huge difference. While the end result, that overgrowth of abnormal lymphocytes, might look similar, the underlying triggers and the typical patient profile can be really distinct between dogs and cats.
Okay, so when a dog is actually developing AOL, what might an owner first notice? The information says the signs are often nonspecific, which must make it hard to catch early.
It absolutely can. Things like, anorexia, loss of appetite, weight loss, just general lethargy.
Things you could see with almost anything, really.
Exactly. They're very common signs for lots of different illnesses, which really highlights the challenge in getting an early diagnosis.
But a vet might pick up on more specific things during an exam, like an enlarged liver and spleen. Hepatosplenomegaly?
Precisely. That infiltration we talked about, it can cause those organs to swell. And similarly, you might feel mildly or moderately enlarged lymph nodes. That's lymphadenomegaly.
And what about bleeding?
Yeah, those little pinpoint hemorrhages under the skin, petechiae, or the larger bruise-like ones, ecchymoses, those can show up.
Because of low platelets.
Exactly, stemming from that low platelet count caused by the bone marrow being suppressed.
Okay, so considering all this, the cell proliferation, the impact on blood cells, the organ involvement, these signs, what's our sort of mission here? What are we trying to really understand from this material about canine AL?
I think the goal is to really get a solid grasp of the essentials. Based on this info, what are the potential triggers? How is it actually diagnosed? What treatments are out there? And frankly, what's the usual outlook?
Right. Let's start with those triggers then. What might cause this in dogs? The info says the exact causes are, well, suspected, but not really proven. That feels common for cancer.
It really is. We often don't have a single smoking gun. Several things are suspected in dogs, though. Maybe genetic factors, exposure to ionizing radiation.
Like from what? X-rays?
Potentially high doses, yes, or other radiation sources. Also, maybe certain oncogenic viruses, cancer-causing viruses, though the link isn't as clear-cut in dogs as FLV is in cats, and even, ironically, some chemotherapy drugs.
Really? Chemo drugs can cause cancer?
Certain types, yeah. Alkylating agents are mentioned. It's a known risk, sometimes causing secondary cancers down the line.
And the genetics part, the information gets a bit more detailed there. It mentions specific mutations, missense mutations, and tandem duplications in genes like FL3, TKIT, and ARAS.
Yes, those are oncogenes, genes that, when they go wrong, can help drive cancer. Finding these specific mutations, like an FLT3 or TKIT, is significant.
How so?
Well, these genes normally help control how cells grow and mature. So mutations here can mess up those controls, leading to that uncontrolled proliferation we see in leukemia. Identifying these isn't just, academic, it actually points towards potential future treatments.
Ah, like targeted therapies.
Exactly. Therapies that could specifically attack cells with those particular mutations, rather than the broader approach of traditional chemo. It gives us insight into the molecular nuts and bolts.
And just to circle back to cats for a second there, the cause is much clearer, right? Aval V infection.
Much clearer link, yes. Fellow V actually inserts its own genetic material into the cat's DNA, and that can directly disrupt genes and lead to leukemia.
Okay, let's shift to diagnosis. You said earlier it's tricky because the signs are vague. The information really hammers home the difficulty in telling all L apart from other stuff.
It does. The way it looks clinically can mimic a whole range of other diseases. That's why a really thorough workup is just essential.
And the list of possibilities, the differential diagnoses, is pretty long. Things like infections, toxoplasmosis, distemper, ehrlichiosis.
Right, serious infections can cause some similar signs, like lethargy and changes in blood counts.
Also aplastic anemia, metastatic cancer spreading to the marrow, and multicentric lymphoma involving the bone marrow. That last one sounds particularly easy to confuse with IL.
It can be, especially since both involve lymphocytes, but there's usually a key difference highlighted here.
Which is?
Typically with lymphoma, you see much more obvious swelling of the lymph nodes all around the body, that bulky peripheral disease, and often less dramatic involvement of the bone marrow and blood compared to ILL.
Whereas ILL is more about the bone marrow and blood being heavily involved from the start.
Generally, yes. Significant bone marrow infiltration and often lots of abnormal cells circulating in the blood with maybe only milder lymph node enlargement, but it's not always black and white, which is why further testing is critical.
That makes sense. It's about where the cancer is kind of centered. What else is on that differential list?
Other types of leukemia need to be ruled out, of course, and also myeloproliferative disorders. Those are other cancers affecting blood cell production in the marrow. Getting the right diagnosis dictates the right treatment, you see.
Absolutely. So if the signs are vague, what are the actual diagnostic tools? The CBC complete blood count is mentioned as being really important.
Crucial first step. The CBC can give us big clues. The info points out some really common findings in dogs with ALL, like normocytic, normochromic, non-regenerative anemia.
Okay, break that down.
Sure. Normocytic, normochromic just means the red blood cells that are there are normal size and have the normal amount of hemoglobin, but the key part is non-regenerative.
Meaning the bone marrow isn't responding, not making new red cells to replace the shortage.
Exactly. The factory shut down, basically. And this type of anemia is apparently seen in like 98% of cases, according to this source. Very common.
Wow. And it's not just red cells, right? Low counts of other cells, too. Neutropenia, thrombocytopenia.
Yes, very common too. Neutropenia, low neutrophils, a type of white blood cell important for fighting infections, seen in about 78% of cases here. And thrombocytopenia, low platelets, in a whopping 90%.
That points straight back to that bone marrow suppression, the myelophysis.
It really does. The leukemic cells are just taking up all the space and resources. Interestingly, though, the CBC doesn't always just show high white blood cells.
Oh.
Sometimes you see that increase in lymphoblasts circulating lymphoblastic lymphocytosis. But other times, the overall white count might actually be low leukopenia, or you might see both low normal white cells and the presence of blasts. It varies.
That's important. It's not just a simple high count. You need to look at which cells are present and what the other lines are doing. What about blood chemistry? Elevated liver enzymes are mentioned.
Yeah, that can pop up. It's not specific just to ALL, but it could suggest the liver is involved, maybe infiltrated by the leukemic cells or stress for other reasons. It adds to the picture.
Okay, now we get into the really specific tests. Bone marrow analysis sounds like the gold standard here.
It really is. You have to look at the source. An aspirate sucking out some liquid marrow or a biopsy taking a small core sample lets you see exactly what cells are in there.
And for ALL, you're looking for?
A massive increase in those neoplastic lymphoblasts. The guideline mentioned here is usually more than 30% of the cells in the marrow being these abnormal blasts. That's considered the definitive hallmark.
And presumably you'd see fewer normal cells.
Right. Depending on how advanced it is, you'll often see low numbers of the normal precursors for red cells and other white cells, and also fewer megakaryocytes, the cells that make platelets. It confirms that replacement process is happening.
What if it's hard to get a good aspirate sample?
Then a core biopsy is really useful, and you can do special stains on it, immunohistochemistry or enzyme stains like peroxidase and chloroacetate ester. These help tell different types of blood cells and different types of leukemia apart.
Okay. Then there's flow cytometry. Sounds complex. How does that work?
It's pretty sophisticated, yeah. It uses antibodies tagged with fluorescent markers that stick to specific proteins, antigens on the surface of cells. You run the cells through a laser, and a machine detects the markers.
So you can identify different cell types based on their surface markers.
Exactly. For leukemia, we look for markers like CD45 found on most blood cells, CD34, which is often on immature or progenitor cells, CD18 on leukocytes, and then markers specific to B cells like CD79A or T cells like CD3.
And this helps distinguish ALL.
It can, yes. For instance, the information notes that most canine AL cells are positive for CD34, whereas most lymphoma cells, even if they're in the marrow, are typically CD34 negative. So that can be a really helpful differentiator.
Especially in those tricky cases overlapping with lymphoma.
Precisely.
And if things are still unclear after all that, there's PAR, PCR for antigen receptor rearrangement.
Yes, PIR is another layer. It looks at the genes that code for antigen receptors on lymphocytes. Normally, you have a huge variety of these receptors in a healthy immune system.
But in cancer,
In a cancer like AL, all the cells came from one original rogue cell, so they're clonal. They all have the same or very similar antigen receptor gene rearrangement. PAR detects that clonality.
so it confirms you're dealing with a cancerous population.
It helps confirm it, yes.
Yeah.
Especially useful in those really ambiguous cases.
And finally, imaging. X-rays, ultrasound.
They play a supporting role. They won't diagnose AL definitively, but they can show things like that, enlarged liver and spleen, confirming organ involvement, help stage the disease, see the bigger picture.
But the key remains the bone marrow tests.
Absolutely. Bone marrow aspirate and biopsy are fundamental, as the information reiterates.
Okay, so we've navigated the tricky path of diagnosis. Let's talk treatment and prognosis. The info mentions treatment is often outpatient.
Often, yes, especially the initial chemo stages, as long as the dog is relatively stable. If they need intensive supportive care, like IV fluids or management of severe side effects, then they'd be hospitalized.
And transfusions might be needed.
Definitely. If the anemia is severe, they'll need red blood cells. If the platelets are dangerously low, platelet transfusions are critical to prevent bleeding. Sometimes plasma, too, for clotting factors. It's about managing those cytopenias.
Now, for the actual treatment plan, the information strongly advises consulting a veterinary oncologist.
Very strongly. This isn't something for a general practitioner to manage alone, usually. Oncology specialists are up to date on the latest complex protocols and can tailor treatment.
Right. It does mention one advanced option: allogeneic bone marrow transplant, using donor cells.
Yes, using those CD34 positive stem cells from a matched donor. It's done after initial chemo gets the dog into remission. It's potentially curative, but as the source notes, it has limited availability. Finding donors, the cost, the specialized facilities, it's not a common procedure yet.
So what are the more standard medications used?
L-asparaginase is often mentioned as an initial drug, an induction agent, and it notes pre-treatment with diphenhydramine and antihistamine is important to reduce reaction risks.
And then usually combination chemotherapy.
Yes, multi-drug protocols are standard. The info lists a common combo: prednisone, vincristine, and cyclophosphamide.
And the outcome with that?
Well, the source says it might lead to partial remission or sometimes complete remission, but often. It's short-lived.
That's tough. What about other drugs, cytosine or iberoside?
That's another one mentioned, often given as a slow infusion, a constant wait infusion. But it also carries risks, like causing further drops in platelets or other blood cells myelosuppression.
So the treatments themselves can worsen the blood count problems, at least temporarily. It's a real balancing act.
It absolutely is. Managing the disease versus managing treatment toxicity. The source also mentions that sometimes, once the initial high number of leukemic cells is reduced and blood counts start to recover a bit, more aggressive chemotherapy might be used.
Trying to deepen the remission.
Exactly, trying to achieve a more durable response.
Now, there are some serious potential complications mentioned. Acute tumor lysis syndrome.
Yeah.
Especially with high cell counts.
Yes, that's a critical one. When chemo kills a massive number of cancer cells very quickly, the cells break open and release their contents, potassium, phosphorus, nucleic acids, into the blood.
And that causes problems.
Big problems. High potassium can cause life-threatening heart rhythm changes like severe bradycardia, a slow heart rate. High phosphorus can damage the kidneys. It's an emergency.
How is it managed?
Aggressive 5E fluids to try and flush the kidney's high-rate diuresis, sometimes medications to manage the electrolyte levels. And the source even mentions leukoreduction beforehand in very high-risk dogs, using a machine to physically filter out some of the excess cancer cells before starting chemo.
Wow. Okay, so that's a major risk to be aware of at the start of treatment. And ongoing monitoring is obviously key. Blood counts, bone marrow checks.
Absolutely essential. You have to track the response. Are the cancer cells decreasing? Are normal cells recovering? And you have to watch for treatment toxicity, adjusting doses as needed.
Sadly, the information also highlights hemorrhage, bleeding due to low platelets,
Yeah.
as a major cause of death.
It remains a huge challenge. Even with transfusions available, severe thrombocytopenia is incredibly risky and a common reason why dogs with LLL are ultimately lost.
So bringing it all together, the overall expected course and prognosis, it sounds like remission is possible initially.
Often achievable with that first round of chemo, yes. Many dogs do respond initially.
But the long-term picture.
The long-term prognosis is generally described as grave. The disease tends to become resistant to the drugs relatively quickly, often within weeks or months, and a relapse occurs.
Very sobering. Despite all these treatments, it's still an incredibly tough disease.
It really is. Developing resistance is the major hurdle that limits long-term survival for most dogs with LLL currently.
Okay, well, wrapping up this deep dive based on this info, the key takeaways seem to be, all L is a bone marrow cancer. Lots of abnormal lymphocytes crowding things out, causing blood cell shortages, maybe spreading to organs. Diagnosis isn't always straightforward, needs blood tests, but really hinges on that bone marrow analysis.
Right, and specialized tests like flow cytometry and PAR can be vital.
Treatment involves chemo, supportive care like transfusions, but even with that, the prognosis is unfortunately guarded because the cancer often comes back resistant.
That captures it well. And that point about needing a veterinary oncologist, absolutely crucial for the best possible management plan.
Definitely. So that leads to a final thought to leave you with. We heard about those specific genetic mutations, like in FLT3 and c-KIT, being found in canine AL. Given that, what kind of future research directions might actually lead to more targeted therapies? Could understanding those genetic drivers unlock treatments that are more effective and less toxic than broad chemotherapy, and maybe, just maybe, start to improve that currently grave prognosis? Something to think about. Thanks for joining us for this deep dive.